The business of medicine is constantly changing. The review by Resolve discusses current contract issues for physicians, compensation trends, and tips for a successful career. Every physician's contract and career is different, and nothing in this episode should be considered legal advice. If you have specific questions about your career, please consult with an attorney. Now, on to the show.
Okay, well, welcome back to the review. Today we have a special guest, Dr. Yalda Jabbarpour. She is a family medicine physician who currently works for MedStar, did her undergrad at UCLA, med school Georgetown, residency Georgetown, and then also is the director of the Robert Graham Center. Is that correct?
That's all correct.
Got it all right. Well, I appreciate you being on here with us today. We love to talk all things physician employment. You're obviously in family medicine, and so we want to dig specifically into that area today. But do you want to start out and just give us a little bit of background on how you got into medicine, why family medicine and not a different specialty?
Yeah, it's a great question. So I think when I don't have family members, first of all, who are doctors. So when I started medical school, I don't think I fully understood the concept of all the different specialties that were there. Obviously knew we had pediatricians, and I think I knew we had OBGYNs. But other than that, I hadn't really experienced, luckily, healthcare myself. And so besides pediatrics and OBGYN, so it was kind of, a clean slate. And really, I found that and you'll hear this from so many family medicine doctors, every rotation I went to, I was so interested in.
Yeah.
I love my cardiology rotation. I love my pediatrics rotation. I love my OBGYN rotation. I love my adult medicine rotation. And so, family medicine was great because we could combine all that. But I think probably more importantly, at least where I trained, it was the family medicine doctors who were the most involved in the community. And meeting patients where they are, understanding that, yes, there's textbook medicine, but there's also, patient desires, the patient in the context of their family, their community, and putting all of that into how we treat people. Because honestly, if I tell you to take a medication and for some reason that does not, mesh with your sense of self, or you can't afford it, or your family members have told you not to take it for some reason, you're not going to take that. And so I love that family medicine put that all together. And so I just knew it was the specialty for me.
Oh, that's great. So how did you get connected with or get into the Robert Graham Center? Tell me about that.
Yeah, so, I went to medical school in DC for a reason. I think health policy is huge in the DC medical schools in general, regardless of specialty. And so I was always kind of health policy interested. After residency, I went and worked in San Diego full-time for a large medical group. And the medical group was run well. It was just the system, the larger healthcare system barriers that were really impacting how we could practice as doctors. And it was nothing like I imagined it to be. It wasn't like how it was in residency, where I just had to worry about being a doctor. There was so much other stuff at play. So we were moving back to Washington, D.C., and I really made the decision, I really need to learn more about health policy and how it really impacts what we do day to day as physicians, and why the system is as broken as it is and set up like it is. And so I did the health policy fellowship at Georgetown.
Sure.
That is through the Robert Graham Center. That's how I got introduced to the Robert Graham Center, and I've been here ever since.
So how much time do you spend patient facing versus at the center?
So currently I'm 20% patient facing and the rest is at the center.
Gotcha.
Yep. But I've whittled that down as I've kind of grown in my career. So I was 100% at first, then 80, 60, and now I'm 20.
Okay, great. Well, I want to talk. You have a very unique perspective, I think, being in that kind of policy space, and a lot has changed probably since you were in, med school, with the way physicians are employed and who they go to join, and who they're contracting with. And so, I guess from your point of view, give us your quick overview on the state of medicine for physicians in family medicine. Who are they working for? What does that look like?
Yeah, it's changed, right? So you're right. When I was in medical school, I think, especially in family medicine, there were a lot of privately owned practices, not physicians were not necessarily employed by health systems or hospitals. Currently, I think our data shows actually that a majority of family physicians are employed by a health system. So they might have had their private practice, but then it was bought up by a larger health system. Um, Most still work outpatient, although many do outpatient, inpatient care. But the employment landscape has really dominated, meaning the health system landscape in terms of having employed physicians has really dominated kind of family medicine at this point. There is a growing sector of family physicians who have left all of it behind and are doing direct primary care.
Yeah.
So I guess that's a form of private practice. And then, of course, we know, just like with any specialty, there is private equity entering the space. It's not as big in family medicine as it is with some other specialties, but that's something we're also keeping an eye on. But like I said, right now, if you're going with majority of us are employed by health systems.
Does your data show any distinction in geographic areas as far as like, are there pockets of the country that are heavier in the employed side versus private practices, or is that pretty consistent across the US?
I think it's pretty consistent, although I will say that looking at private practices, they're probably more common in rural areas. So
Sure.
big health systems went to rural areas last, but they are buying up rural practices as well.
Yeah.
Yeah.
Yeah. I mean, we see the, the contracting side of it, right? We're helping physicians look at their options as they're coming out of training or as they're moving mid-career. And so it certainly is heavy on the employed side, right? I mean, there are certainly some that are still joining private practices, but it is the minority of what we see as well. So that's really interesting. Has there been any tracking as far as satisfaction, job satisfaction, burnout rates, things like that between the different types of employers?
That is a really good question. I don't think so. We have a survey that we do of family physicians through the American Board of Family Medicine that looks at burnout rates of family physicians. I don't know that we've found any significant difference between, when you're looking at the data,
Yeah,
between burnout rates in one setting or another in terms of employed versus private practice. But I think that's because the numbers are too small on
sure.
the private practice side. I think if you talk to family physicians, which we do a lot of qualitative data, so if you talk to family physicians, I don't know that their burnout rates are different, but I do know that family physicians who tend to work in private practices feel like they have more autonomy.
Yeah,
And we know that lack of autonomy is one marker of burnout. So in that way, anecdotally, I think probably working in an employed setting, burnout would be higher, but we're not
yeah,
seeing it in our data.
yeah, sure. And that it is something that a lot of our clients want, right? Is autonomy. They want to have their call schedule protected, or they want to have their locations that they work at protected, so they can
Yeah.
control something, right? I mean, they control what
Yeah.
they can control since they're not running the entire health system. So that it'd be consistent with what we see. Um, I read that you publish a lot, right? I mean, you're doing a lot of research. One of the things that you recently put out was titled "Lifetime Impact of the Gender Wage Gap in Family Medicine." And
Yeah.
I would love to get your thoughts and takeaway on that, because that hits very close to home for what we do.
Yeah, I love that you read that. So we started looking at the gender wage gap in family medicine around the time where everyone was looking at gender wage gaps,
Sure.
several years ago. And I think before we started the study, we kind of felt like that happens in more male dominated fields. Family medicine, it tends to be closer to 50-50. We don't think it's going to happen in family medicine, but unfortunately, we found with the data that we used, again, that American Board of Family Medicine data, which is self-reported
Sure.
salaries,
Sure.
we found that there was a gap between male and female family physicians. of around $30,000 a year. And we controlled for, in the first study, we controlled for seniority because
Okay.
people always say, well, yeah, it's because women just haven't been in the field as long. So of course there's more, males in senior positions, they're going to make more. We controlled for seniority. We also controlled for hours worked, because that's another thing that people will say is that, well, women are part-time, so of course they're not going to make as much. So we controlled for all that. In a follow-up study, we also controlled for different things that impact family medicine doctors more specifically, because family medicine doctors can work in a variety of settings. You can work outpatient, you can work inpatient, you can work in the urgent care, ED, you can have a specialty in sports medicine, a specialty in OB. Even when controlling for all of that, there was still a gender wage gap. So there's definitely some bias that is going into this in terms of hiring practices. Probably also some education and mentorship that needs to be done for graduating family physicians in terms of their ability to negotiate. And also probably just the way, on average, female family physicians practice compared to their male counterparts might have them bringing in less revenue in a fee-for-service system. So there are multiple things that are probably still leading to this gender wage gap. And so then we thought, okay, well, we know that there is this yearly gender wage gap. What happens if we model that over a career? And we found that when you model that over a career, assuming, we all start our careers kind of in our 30s and then work maybe until our 60s, so a 35-year career, we found that the wage gap over a lifetime was in the millions, and so the fact that you're missing out on that much money for giving the same, if not better, quality of care, because there are some studies that do show that female physicians give better quality of care, is depressing.
Yeah, well, I'm
in family medicine.
really glad you're doing that. We like to do the same thing with, if you accept any, below market wage, right? And you extrapolate that out over 10, 20, 30 years. And if you invest it, even on an average return, it's $1 million plus for any physician, right? And obviously some of the surgical specialties earn more, so it's even more dramatic. But I want to go back to one thing that you said, because I'm really curious on this. Why is it that, two things: one, female physicians are giving better care, and two, how does that then, in our current modeling and current comp plans, how does that affect their compensation?
Yeah, so I think we have to think about, well, what does better care mean? What does higher quality care mean? The studies not done by us, but done by other groups, have shown things like better control of diabetes, hypertension, the chronic conditions that we tend to look at, better, lower readmission rates in hospitals. But I think also probably more importantly for the patient, higher patient satisfaction in terms of what they feel they're getting from their care. And I think that last part maybe plays into why, on average, I mean, we're generalizing here. Every person is different.
Yes, of course.
But why, on average, female physicians tend to bring in lower revenue. And that has to do with the fact that we have a fee-for-service system predominantly. So, it's not based on how much time you spend with your patient. It's based on how many codes you can bill for, right?
That's right.
And so for patients, for their satisfaction, a lot of it is, are you spending time with me? Are you face-to-face with me? Are you taking care of all my issues in one visit instead of bringing me back for 4 or 5 different visits? Because honestly, if we bring them back for 4 or 5 different visits in a fee-for-service system, we obviously make more money.
It's good for everybody, right? For the system, not for the patient, but everybody else.
Yeah. But the way that, and others have done these studies where women just tend to take more time with their patient in the room, delving into more issues in one visit.
So I'm going
way
to
that
zoom
we
out
have
on that for
system
1
is-
second, because I
yeah,
think there's going to be some people that are watching this that don't, like a resident may not fully understand this. So that
yeah.
in your contract, when we see it, it's usually you get like a base salary, and then
Mhm,
you're going to have to cross a certain threshold of work RVUs, which are
mhm.
directly, from the CPT code you enter turns into so many work RVUs. Once you cross that threshold, you're going to bonus, and so it's very
Yep,
much a to really, you know, probably not do enough service, but it's like the more widgets you produce, the more you're going to get paid, right?
yep,
And so if female physicians are producing less widgets, right, the
right,
reimbursement is less, but the patients are maybe happier, at least on the studies that
yeah,
you're looking at.
yeah,
And so I do think quality, right, generally has been talked about. We've seen quality bonuses start to come into comp plans, but it's usually 5 to 10%, right, of the total comp. It's not, again, generalizing across the board, not the majority of your compensation. And so there's no incentive financially, at least, to spend more time with patients, right? You're actually
exactly.
incentivized to go through them quicker.
Exactly,
Yeah.
exactly right. And a lot of even the quality metrics that you are being judged on, maybe I don't know that they're the right quality metrics. Let's put
Right.
it that way.
Right.
They don't necessarily, they're called quality metrics. I don't know that they actually translate into quality care.
Yeah.
And I'm not sure how much physicians can actually impact them.
Yeah,
Um,
that's the thing that our physicians are most frustrated with is they're like, I have no control over that 10% of my comp because it feels
no,
so subjective. I never know if I'm going to get paid that amount or not. And so
yeah,
then they almost would rather have the work RVU structure,
right.
which is maybe not good for medicine in general, not good for the patients. And so it
Yeah.
feels it's an interesting problem. I guess I'll put it that way.
Yeah, and it's a big problem I think the
Yeah.
health policy world is trying to tackle because we do want to move towards a more value-based system.
Right.
But then if we're going to move towards a value-based system, what metrics are we using to judge value? And
Mhm.
can physicians control those metrics or not by the type of care that they provide?
Right.
Yeah,
Really
that's a hard
interesting.
question to answer.
Yeah, yeah. No, you and I aren't going to solve that one today.
No.
Um, so I guess any takeaways then for a resident or a fellow, somebody that's young coming out, takeaways on just the status of being a family medicine physician. What should they do?
Yeah, so before you sign that first contract, absolutely have someone look at it because that first salary you get out of residency or fellowship is going to determine all your future salaries. So,
Correct.
um, absolutely have someone look at it. Don't rush into signing. Um, Number two, negotiate. Even health systems will tell you that your salary is non negotiable. They will say this is what we pay every starting family medicine resident or every starting family medicine physician, but there are ways to negotiate. Are there leadership positions that you can take which would give you more bonuses? Is it something else that you want to negotiate that's not necessarily salary? Is it, protected academic time, protected research time, more vacation? If that means taking a class on negotiation or finding a mentor who's great at negotiation, do that before you sign the contract. Um, and then I would say use the tools at your disposal that we have within the AAFP, because the American Academy of Family Physicians. I will say that when I was going to sign my first contract, first of all, I was being paid what, $55,000 as a resident. So anything looked good,
Yeah.
like, because
Right.
I was at least doubling, tripling my salary at that point,
Right.
right?
Right.
So I didn't know how much I should be asking for. We now have a dashboard for AAFP members where other members have put their compensation into this dashboard. So you can
Mhm.
go and say, okay, I am a family physician starting a job in Maryland. What are other family physicians in Maryland making? What should I ask for? What should I be
Yeah.
looking for when I'm applying for a job? So I think use those transparency tools to your advantage.
Yeah, I completely agree. That's one of the reasons that we, partner with AFP is we feel really strongly about, if you need help, right? Find the information you need, find that data, find somebody that does this all day, every day, because you're right. They're going to tell you it's standard, right? Everybody says it's
Mhm.
the same contract everybody signed, and you're like, boy, when we look at the information, that's not the case.
Yeah.
Um, and I want to go back to the gender wage gap for just 1 second, because we've got some stories and some things that we've seen internally where exact same position, male and female candidates, and it's things like one has a signing bonus and one doesn't, right? And so
Yep.
it's not even always the conversion factor, the base salary. It's these little incentives that are getting trickled
Yep.
in. And we'll even ask the clients sometimes, did you negotiate for that already before you came to us? And they'll say, no, it was just there. And then it wasn't just there in the female, contract. And so it's discouraging. I mean, it's frustrating when you see that stuff, but it
Yeah.
absolutely exists. And so you have to
Yeah.
be informed. You have to know what you're getting into, get access to that data. So couldn't agree more. You said one thing early on, and I want to come back to it again. You said you hadn't been in healthcare. None of your family was doctors and things like that. And now that you've been exposed to it, would you still encourage your kids or in the next generation of people coming through to go into medicine?
Oh, that's the $1,000,000 question. Well, no, not my children, because my children faint at the sight of blood. So I
Okay.
just don't think
Not for
they're
them.
cut out for it.
Nope. Okay.
Yeah, I absolutely would, because it has been a very, very fruitful and stable career. I mean, I see my friends around me who maybe got started in their careers earlier. They're always worried about losing their jobs, right?
Yeah.
Like,
Yeah.
you don't have to worry about that as a physician. Now, not to say that we don't have hardships in our line of work. We absolutely do. Burnout is a big one. Just the way the healthcare system is set up in general is another big one.
Yeah.
But I do think that there are changes on the horizon, things that we're advocating for at the AAFP and others are advocating for within the healthcare system, that will make practicing medicine easier than it is currently. I'm hopeful for that. The other thing is that, especially a career in family medicine, it gives you so much latitude to do whatever you want with it. I mean, I never thought, I only thought that I would be working 100% clinical. I never thought that I would be doing health policy, research, teaching, mentoring. I'm able to do that in family medicine because there are so many opportunities in family medicine. I will say, every time I meet a family medicine doctor, they're doing something different, right? They're
Sure.
either, okay, I'm in a DPC practice, or I'm employed, but I do inpatient, outpatient plus OB, or I work 100% outpatient, but I really have this specialization in sports medicine. Everyone is doing something different, and just having the ability to be creative like that in your career is so important. So yes, absolutely.
How do you think AI is going to impact family medicine?
Oh yeah, that's a great question. And that is what I'm talking about when there are changes on the horizon that I think will help,
Yeah.
because one of the biggest barriers for entry, I would say, for a med student choosing a family medicine career is the administrative burden they see family
Of course.
physicians going through. AI can take that all away. We've already started with ambient AI in most practices around the country. And so, do I have to take notes anymore? No, I can just talk to the patient and then go to my notes at the end of the day, and they've been done for me, and I just have to review them. That's great. We're finding ways within our clinical practice to have AI do some of the triaging of portal messages, because that is another big burden that,
Yeah.
we don't get paid for answering portal messages, and it takes a lot of time. So having AI help us with that. There are so many ways you can use AI to reduce admin burden, insurance prior auths, all of these things that don't allow us to be the doctors that we want to be, can get taken away by the implementation of AI. So we can focus on just the patient, the science, the medicine, and that's it. So I really do think that that is going to be a positive change.
Yeah, I agree. I mean, and there's always a complaint from our clients on admin time, right? They
Oh
want to
yeah,
carve out, point 0.2 or point 0.3 or even point 0.1,
yeah,
whatever it is, just for that, because they know the patient facing time is important, but it's going to just clog them up later on. They're going to have to do these
totally.
charts at home at night, whatever it is. And so, yeah, I think quality for the patients, right? If nothing else, is, hey, I can look at you again and not have to look at this computer the whole time.
Yeah.
Those things are great, and hopefully AI can certainly help with that.
Yeah, absolutely. I have no fear that AI is going to take over the practice of something as complicated as family medicine, because
Yeah.
what we do is not algorithmic. You can't really teach, the computer to do it, but it can take away the hard parts of our job, or the parts of our job that are not the science and the medicine.
Yeah. Yeah. Well, that's great.
Yeah.
Well, I appreciate your time. I'm not going to keep you too long. We appreciate the work you're doing and all your insights, and maybe we'll have you on in the future.
Yeah, absolutely. Thanks for having me.
Alrighty. Have a good day.
Okay, you too.
Bye.
Bye.